Hello, everyone, and welcome to our seventh session of CME Palooza Fall 2023, Improving Patient Care for the LGBTQ plus community through continuing education, a panel discussion. Our session today is sponsored by DKB Med. Our moderator is Tricia Wilson from Optum Health Education. We'll turn things over to Tricia in a minute. But first, our sponsors. Let me get my list. Okay, a big thank you to all of our gold sponsors, Academy for Continued Healthcare Learning, Clinical Education Alliance, Med Learning Group. Big thank you to our silver sponsors, Academic CME, DKB Med, Haymarket Medical Education, Helio CME, Integrity CE, Medscape, Platform Q Health Education, RedMed Ed, Talem Health. And a big thank you to our bronze sponsors, Answers in CME, Antidote Education Company, Bonum Continuing Education, CME Institute, Semiology, Hippocrates, Excalibur Medical Education, Global Education Group, Infograph Ed, Integritas Communications, Iridium Continuing Education, MedIQ, Partners for Advancing Clinical Education, PrimeMed, Peerview Institute for Medical Education, RMEI Medical Education, Vindico Medical Education, and Right Medicine. Two ways that you can ask questions during CME Palooza. You can use the CME Palooza text line to send in a question, 267-6660-CME. You can also open up the viewing window in YouTube. Just click on the Watch on YouTube on the lower left corner, and you can enter in questions within the YouTube chat function. I'll be monitoring both of those, so feel free to use either one. Ooh, my slides are going without me. That's fun. There we go. Interacting with Poll Everywhere. We'll be incorporating audience response questions throughout the presentation, just like most of the others so far today. Hopefully you already have this, but a big thank you to CME Outfitters audience. A big thank you to CME Outfitters for sponsoring the audience response system. So you can either download the Poll Everywhere app and put in CME Palooza 005 or type in the URL there at the bottom as well. Either of those will work. We do have a number of questions throughout the session, so you might as well get that ready to go. And then the last thing for me, speaker disclosure. Any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, its parent company, or affiliates. So with that, I will turn things over to Tricia. Thanks, Tricia.
Great. Thank you, Derek. And thank you all for joining us today for our panel discussion on improving patient care for the LGBTQ plus community through continuing education. Next slide. I am Tricia Wilson, and I am a program manager for Optum Health Education. I am passionate about health equity and today's topic in particular, and I'll get started by allowing my colleagues Chris and Rachel to introduce themselves. Chris?
Thanks, Tricia. Hi, all. I'm Chris Napolitan, Managing Director for Prime. Happy to be here to participate in this important discussion. Rachel? Rachel, you might be on mute.
Hi. Hi, all. Good afternoon. I'm Rachel Every, Associate Director in Global Medical Education Oncology, and happy to be here. And thank you to CME Palooza and the sponsors for inviting us. And I'm going to be handing it back to Trish to walk you through the agenda. Trish?
Thanks. Next slide, Derek. So today's discussion is going to follow this loose agenda. You may feel free to send your questions in at any time, and we will address those at the end. We're going to begin by discussing the why. Why is there a need for continuing education to advance the care for the LGBTQ plus community? We'll discuss approaches we have taken and the resulting outcomes. From there, we'll talk a bit about how to keep the spotlight on these efforts moving forward. Next slide. It's important to understand some of the demographics as we begin. As of 2019, 9 million people in the US have identified themselves as LGBTQ+, and that number has risen in subsequent years. There are over 500,000 same-sex couples and over 700,000 transgender people in the United States. A 2021 survey indicated that Gen Z, people born between 1997 and 2004, are most likely to identify as LGBTQ+, and that number is growing. But what's troubling about these statistics is the information you see on the right. 17% of LGBTQ adults have experienced discrimination in the doctor's office, a place where a person should feel safe, heard, and cared for. 29%, there's a 29% chance that a trans person has had to educate their own doctor about their health issues. 20% of LGBTQ+ adults have said they avoid seeking medical care out of fear of discrimination. A related statistic shows a recent survey of a urology clinic where 80% of the healthcare team said they didn't have the necessary training to care for their trans patients. 80%. That's astounding to me. These statistics show not only the need for education for the healthcare team, but you can also see a direct correlation to delays in care and disparities in care. Chris, would you like to talk a bit about disparities specific to cancer care?
Absolutely. Thank you, Tricia. So, Derek, next slide. Each year, approximately 100,000 people who identify as LGBTQ+ are diagnosed with cancer. Yet, as the data on this slide from the OUT study shows, individual and institutional barriers contribute to disparities that can lead to delayed diagnoses and poorer outcomes. So of the 2,700 respondents in this study, 90% reported no environmental indications of welcoming care at the place where they received treatment. And of those patients who actively sought a welcoming environment, 30% had to travel over 45 minutes. So this data just shows how it can really create delays during a very critical time period. The study also showed how cancer diagnoses are delivered with varying degrees of sensitivity, which can limit patient engagement and hinder participation in follow-up care. And lastly, patients reported difficulty finding education tailored to their specific needs, with nearly 90% reporting post-treatment care plans did not include resources specific to the LGBTQ+ individuals. So I'm going to pass it back to Tricia, who's going to provide some powerful qualitative insights that will really bring these stats that we shared to life.
All right, next slide. So all of this together gives us a very powerful reason why we need to focus more on continuing education in this area. Here are just a few real-life scenarios the Human Rights Campaign noted. A transgender woman waiting for her first physical in years stated that when she walked towards the women's bathroom in a waiting area, the receptionist jumped up and told her to use the McDonald's restroom down the street. She stated that she felt like leaving and never coming back. A gay man hospitalized for a lung condition stated, "After I mentioned that my husband would be visiting me, the staff who had been friendly turned very cool, and I saw a lot less of them, even when I needed help." A lesbian mother after the birth of her first child said, "As I walked back to see my partner and our newborn, an employee stopped me and asked who I was. When I said the other mom, she rolled her eyes and walked away saying, 'I don't believe this.'" A Lambda Legal study had 56% of respondents reporting that they had experienced at least one of the following types of discrimination from healthcare providers. Again, the people who are supposed to make you feel heard and safe when you visit them. They were discriminated against by refusing to provide needed care, refusing to touch them, or using excessive precautions, using harsh or abusive language. Imagine that. Imagine going into your doctor and being verbally abused, blaming them for their health status, or even being physically rough and abusive. This really impacts me. I really feel strongly about these statements. These are the things, these are the reasons why education is so needed. We have a video clip, and some of you who may have attended my session at the Alliance on this topic last year, I showed some video clips from the educational modules that we created. And here's one, just again, to emphasize the importance of educating the team.
I was out of the country on business, and my wife was back home in Houston. My phone rang, and when I picked it up, my cell phone, all I could hear was my wife screaming on the other end of the phone, all the way from Houston. And I wasn't quite sure what she was saying, but I could tell she was in pain. I could also tell she was driving, so I asked her to stop, and I asked a friend of mine to call the ambulance, right? So I was doing this from outside the country. Didn't really have any idea of what had happened, and my wife ended up being taken to an emergency room. So you can imagine I was pretty distraught. Somehow we were able to track down what emergency room she'd been taken to, and I called the emergency room from out of the country, introduced myself. I said, "This is Dr. Margaret Wilson. My wife has just been brought in. I don't know what's happened to her, and I really would appreciate, some information." I went on to say really quickly that I am aware that you cannot provide me with the information. I was speaking to a nurse in the emergency room. So I'm going to send you my durable power of attorney for healthcare. Could you give me your fax number and email so I can send that, and that way you can speak to me? And she said to me, "Who are you again?" I said, "That's my wife." And she said, "Do you mean your husband?" I said, "No, we're a lesbian couple. That's my wife." And she said, "Well, I can't give you any information." I repeated again that I would send her my durable power of attorney for healthcare, at which point she cut me short and said, "I'm not interested in that." I still gave her the grace and thought, well, we're 10% of the population. She may not be familiar with how to manage couples. So like you, Michelle, I carry my marriage certificate in my phone. I offered to email that to her as proof that we were legally married. And she said to me again, "I'm not interested in any of that information." It took me calling our attorney in Houston who then called the hospital and got them to accept the documents. I've done a lot of reflection after that, and we had breakdowns, I think, in 3 areas. One, I am a physician. So I had done my due diligence and made absolutely certain that I had a will in place, advanced directives, durable power of healthcare for both my wife and myself. And I was carrying my marriage certificate in my phone. Not a lot of people may know to do that in the LGBTQ community, especially if they're not clinical. So that's one point at which it could break down. And I think that it's our role as providers to ensure that those discussions have been had with our patients who are members of the community. The second area where I think that broke down also is really around unconscious bias mitigation. I think it's important that we have training such as this, both in and outside care delivery, and we have processes in place that help guide the staff in how to deal with LGBTQ couples or people. And I think the third is recognizing that sometimes it's all about a human factor, and recognizing that these relationships look different. I often ask myself what it would have taken for the nurse to just walk across to my wife and say to her, "Someone's on the phone, Margaret Wilson, is that your wife, and can I speak with her?" But that never happened.
How awful was this experience for Dr. Wilson to go through with her wife, and for her wife as well, who clearly was in distress and couldn't have access to her wife, and totally unnecessary. Rachel, can you share a bit about how we can make CE to advance LGBTQ plus a priority?
Sure. Thanks, Tricia. And thanks for the question, for sharing those real world examples, which can be so powerful in terms of raising awareness around healthcare disparities faced by these patients. Also, there are many factors justifying support for CE to advance the care amongst this community. I'd like to make the point that this population will only grow as younger generations feel more comfortable identifying. And as more people identify, we're able to effectively quantify the impact of our supported education. Now, this type of program would have been more challenging to advocate for 10 to 20 years ago with older generations who felt less comfortable coming out. And second, we know from the data and needs assessments that this community are at increased risk for specific medical conditions, including breast, cervical, prostate, colorectal, and ovarian cancers. And third, the experiences and barriers in patient care that Chris spoke to, that contribute to delayed diagnosis and poorer outcomes, generating significant disparities in cancer care. Next slide. This was the slide I just spoke to. Wait, okay, back for a second. Thank you. Okay, and I also want to point out, for example, 25% of the LGBTQ plus patients have postponed or avoided medical treatment due to discrimination. And approximately 20% of the LGBTQ plus patients have been refused care due to clinicians' religious beliefs. And for these reasons, our internal stakeholders have viewed these disparities in oncology care actually as opportunities to educate clinicians to improve patients' lives. So we'd like to take a few minutes now to poll the audience on your thoughts on advocating for education in this area. And next slide is the polling questions. Okay, 1. So, everybody ready? How frequently has developing or supporting education focused on generalized healthcare disparities been part of your strategic priorities? Please select 1. It's not part of my strategic priorities, 1 year, 1 to 2 years, or greater than 2 years. Thank you. Okay, interesting. Nice, happy to see that. Okay, happy to see that. Okay, next slide, please. And if yes, has there been a focus on more specifically the LGBTQ plus care education, just a little more focused? And you can see the answers: yes, no, we're working on education in this area for the future, or maybe down the road.
Next year when we do this, the percentages are going to be higher for yes.
For sure.
Hope so. Nice. Okay, this is good. Okay, so next slide, please. And if your answer is no, why? Is it due to A, limited budget, outcome, or B, outcomes difficult to provide on non-clinical topics? 3, perceptions of impact or patient prevalence. And D, other. Okay, so limited budget seems to be the big one. Or other, actually. And looking forward to seeing what some of those other categories are. So if you could go to the next slide, please. Okay. So what formats have you utilized or would consider utilizing in developing or supporting education focused on advancing LGBTQ plus care? And you can select all that apply. Online activities, live events, including regional meetings, national symposium, social media, microburst type learning, quality improvement initiatives, tethered patient provider education, and practical tools and resources. Wow. Okay, it looks like there's been, okay, this is great.
Quite a good mix.
Yes. Thank you all for that. So effective approaches in CE exist across a variety of formats to advance equitable care. And so, Tricia, can you share an example from Optum Health?
Sure. So as I mentioned before, the education Optum Health Education has done, this is just links to it and just a little overview. We worked with the Care Delivery Organization to create a series of 2 live webcasts offered twice and then endured for 3 years. The Care Delivery Organization also posted it without credit because they wanted to ensure that their healthcare teams would take it. And they were looking at every single person that a patient would encounter from the second they walk through the door, from the person who they check in with, through the medical assistants, the person taking their blood pressure, the physician, the person checking them out, the person scheduling them for a follow-up appointment. Think of how many healthcare providers and how many people, staff people, you encounter when you go to the doctor. There's so many people. And the point was to have them complete these activities to improve the care that they were providing from the beginning. Chris, why don't you tell us a little bit about the initiatives that your team has worked on?
Thanks, Trisha. I really like how your initiative included the entire support staff to create that positive experience for patients start to finish.
Mm-hmm.
So Rachel and I are going to walk through a case study that takes a research-driven approach to address barriers to equitable cancer care. The project was executed in an academic setting through Moffitt Cancer Center, as well as in the community through American Oncology Network and Florida Cancer Specialists. From a design perspective, we first assess system and individual level factors that affect equitable care, including patient and provider perspectives and experiences. So Derek, if we can bring up the next slide. So just to orient you, the orange data on this slide reflects the aggregated baseline results from over 800 patient respondents, while the data in the purple reflects baseline results from 115 providers. On the left side, note only a quarter of patients feel comfortable disclosing their LGBTQ identity versus 65% of providers that think their patients feel safe disclosing. The bottom left chart shows almost all patients reported that their clinic intake form asked about gender identity. However, only 34% of providers actually knew where to find this information. And lastly, in the center, you can see that patients reported how they would feel more confident in their care if their clinic shared public statements of support and if their providers shared their pronouns. However, no providers reported doing this. When you consider these discordances, unfortunately, it's not surprising that 80% of the LGBTQ plus patients reported not receiving regular preventative cancer screening. So all of this data was actually built into education sessions that took place at each of the participating clinics in which cancer care teams analyzed their own data and developed specific action plans for improvement. Rachel, can you share some key qualitative insights from these clinic-based sessions?
Sure. Next slide, please. Thanks, Chris. Okay, so absolutely. This slide includes quotes that speak to experiences, perspectives, and questions that HCPs encounter in providing cancer care to this community. The first quote on the left highlights how nuanced and tricky conversations can be for an HCP. They explained how a patient was upset when asked about their gender identity and sexual orientation. In the second quote, the doctor acknowledges how nonverbal communication can impact a relationship with a patient. When they saw a transgender person that did not disclose their identity before their exam, the doctor discovered that the patient was transgender during the exam and displayed a nonverbal surprise reaction, which the patient then observed. And then the next two quotes on the right highlight how it's not always easy to keep inclusive gender identity and sexual orientation language top of mind when documentation may not be easily accessible and conversations with LGBTQ plus patients do not happen regularly. And then the last quote highlights how these clinic sessions are also used to address important clinical questions, such as fertility treatment eligibility based on gender, which oncology clinicians may have less experience with. So these sessions allowed for discussions of challenging clinical topics that generated ideas on how to make improvements in their own practices. And so, Chris, can you share some of the specific action plans that came out of these sessions?
Absolutely. So after having these open discussions and really reviewing their own baseline data, the cancer care teams at each clinic developed specific action plans that included improving documentation within EMRs of preferred pronouns and gender identity of patients, purchasing accessories to display to show inclusion and support, and providing cancer care resources tailored to the specific needs of LGBTQ plus cancer patients. So Derek, if we can go to the next slide, we also developed a toolkit that was informed by the baseline data. And this toolkit was really focused on supporting providers and patients in open communication, inclusive care, and unique treatment considerations for this population. So the toolkit was introduced during these clinic-based sessions and is being implemented in practice now. And just to kind of cap off where we are in the project, so each clinic is now in the process of executing their action plans, for which we'll quantify the results from in the coming months through a follow-up assessment. And we really focused on also too being able to scale the insights from this initiative nationwide through a peer-reviewed journal publication and on-demand video. So as we transition to the next part of our discussion, I'd like to ask Rachel, what are key outcomes that would resonate most from a supporter perspective for a QI initiative focused on improving equitable care for the LGBTQ plus community?
That's a great question, Chris. So outcomes from health equity programs, so targeting, in this case, the LGBTQ community that show an impact on specific therapeutic areas, and in my case, oncology, are particularly important. Ultimately, providing key insights in relevant disease states opens the door for funding these types of programs in the future. I'd also like to make the point, health equity outcomes that distinguish the care setting. For example, academic versus the community clinics, that allows for more focused insights. So this is an important information to my internal stakeholders, because if the goal is to improve care for these patients, then tailored resources, policies, and processes specific to the setting will support this goal. So Chris and I are now going to share key outcomes from the QI program. So next slide, please, Derek. Thank you.
So this slide shows outcomes of the academic versus the community learners from the clinic-based sessions. You'll notice that absolute gains tended to be greater among the academic learners, where greater LGBTQ plus administrative awareness and research are more common. So this was true for the knowledge question in the middle pertaining to the types of cancer that lesbian and bisexual women are at increased risk for, with academic providers showing larger increases in higher post-program scores. However, providers practicing in both settings significantly improved commitment to discuss gender identity and sexual orientation from very low baseline scores of 12% among academic learners and only 1% among community learners. So as we saw from earlier in the presentation in those patient survey results, these discussions were particularly important to increasing LGBTQ plus patients' feeling of comfort and confidence in their care. So this data shows how impactful it can be to build patient insights into education for providers to really motivate behavior change. So Rachel, reflecting back on what you shared earlier on the importance of these disease-specific considerations, were there any noteworthy findings captured from the program?
Yes, thanks, Chris. Great question. So this QI project generated interesting tumor-specific insights that can be so helpful when sharing with my internal stakeholders. So, next slide, Derek. Okay, thank you. Okay. So more specifically, we learned that the LGBTQ plus gastric cancer patients were more likely to engage their doctor and play an active role in planning their treatment. And then conversely, breast cancer patients were less likely to have discussed quality of life issues with their provider and to have been offered LGBTQ plus specific resources. And in prostate cancer, patients were more likely to visit multiple providers in order to find inclusive care, and thus increasing the likelihood of delays in screening or treatment for a very serious condition. And lastly, we saw how ovarian cancer patients were more likely to report that disclosing their identity to their healthcare team is extremely important. So reflecting on these outcomes that Chris discussed regarding HCP's commitment to now discuss gender identity and sexual orientation, you can see how this data shared with my extended teams are noteworthy and practice changing. And so now I'm going to hand it over to Tricia, who will briefly share key outcomes from their initiative. Trish?
Thanks, Rachel. Next slide, please. This is just a very basic overview of some numbers. I won't go deeply into our statistics because I personally don't feel like the number of enrollments and completions is the story here. I think the importance lies instead with the fact that we have to do this at all. Next slide. These are some of our qualitative results from the cumulative from the two indoor sessions that we have and the live sessions that we conducted prior. We were thrilled to see that at least 78% of the evaluation respondents indicated that they would make changes to their practice based on what they learned. But we found that what was most important was their comments. And I'll just read a few of them as we go through here. Better teams turns into better patient care. I would love to make everyone feel included, seen, and heard. Personal stories drive home impact. I think every single person listening here and every single person in the CE industry can agree with that. It's the personal stories. But I think especially when it comes to health equity, when it comes to LGBTQ, when it comes to social determinants of health, those areas, the personal stories are even more impactful. We were thanked for the training. It gave people practical suggestions to direct their interactions with people in the LGBTQ community, and that was the goal. That was the whole point of this. Next slide. Again, just some comments relating to the opportunity to grow and learn, which, again, that's what we want. That's what we want to see from our learners. We want them to take things away that they can actually put into practice. One comment is, thank you for ensuring that we as clinicians and mental health providers are supporting every population equally. And that should be the goal overall for any activity that we do. This comment was very moving for me as well. As a heterosexual male, I have never encountered these types of experience, and this gives me greater perspective going forward. That was the point. The point was to make people think outside of their lived experience. This person said, I think of myself as a strong ally, and went on to explain some of the things that they took away from it. And I think many people will say that I'm an ally, but I didn't know. I don't know what I don't know, those sorts of things. So based on what we've discussed today, the importance of LGBTQ plus education is clear. It's as part of a broad health equity strategy. And Chris and Rachel, the question then becomes, how do we keep a spotlight on this type of education? I'd like to hear from both of you what your thoughts.
So I have two specific things in mind. First, if we're focusing on developing programs that can really bring forth real-world insights pertaining to patient-provider experiences and perspectives, that data can be very instrumental in understanding underlying root causes of disparities in care and ultimately help us address the inequities. The second thing I would highlight is a focus on developing education that can be practical and sustainable. So if you draw back on the quality improvement initiative that Rachel and I shared, The toolkit is a useful resource that can be referenced in practice on an ongoing basis. And then the action plans that each of the clinics developed, we anticipate those being in place well beyond our program concluding. Rachel, anything to add?
Yeah, no, thanks, Chris. I agree with your comments, the importance of the data. So this is especially true for initiatives that may be more broadly focused on addressing disparities in care, where it may be difficult to get detailed outcomes data specific to tumor types and provider settings, for example. However, drilling down to get the right insights can be used to inform medical communication strategies, and continuing to invest in key initiatives focusing on advancing equitable care. So turning it over to Tricia for any concluding remarks and a final polling question.
Sure. No, I appreciate that. I appreciate both of your insights on this area. And specifically some of the things you touched on, Chris. You said about having the toolkit, and there were things that we did with that as well, so that people can refer back to it after the education at any point in time. And I also appreciate that the practices that you were working with are also going to implement some different things to make sure that they are increasing better care for people in the community, which I think is fantastic. I think, your initiative and ours were both excellent in this area. So we have one last polling question for you all now. Based on what you've heard today, will you advocate for developing LGBTQ plus education going forward? Let's just keep it there, 100%. We do understand, sometimes it does not fall into your corporate priorities right now. But part of the point of having this panel discussion was to bring home the importance of this and how it impacts the patients, which is, the bottom line of CE. So I'm really glad that didn't change as I was talking, because I do think it should be 100%. So we'll turn it over now and see if we have any questions that came in.
Yes, we do have a few. Hold on, bring them up. Okay. I think these are all addressed to all of you, so feel free to respond. Bring us up so we can see our wonderful faces. Okay, question number 1 was, have any of you received much or any kind of pushback from your organizations for producing, supporting programs for this particular population? I think everyone, not everyone, but there is some interest in, we've heard how well they went, but were there any issues when you were going through?
I can start on that one. We didn't receive pushback from our organization specifically. We received pushback from some of the providers that we had promoted these modules to. We got some really difficult messages from a Pride post or e-blast that we had sent out. People telling us to take them off our mailing list. They didn't want anything to do with this. They didn't want to hear anything about this. They couldn't believe we were even, promoting anything like that. And, when you look at the climate in the United States, that's not surprising. But it's very disheartening, especially when it is coming from healthcare providers directly.
Right. Yeah, for our initiative, we didn't receive any pushback from the clinics that we enrolled, but you're going to naturally have some clinics, some providers that are going to be more interested in the education than others. And I think one of the tricky things that we're up against is the providers and the clinics that don't want to do this are probably the ones that need the education the most. Mm-hmm. So that remains a tricky dynamic to, I think, navigate.
Yeah, I agree 100%.
Yes, and I'm happy to chime in here too. So to keep the spotlight on this type of education, I'm really excited to share the follow-up survey results and the impact that the follow-up survey results have. And I feel fairly confident that these are going to be quite robust. And I think it'll be clear how initiatives like these are calling for support to improve care for the LGBTQ community in relevant disease areas. So, when you tie it to the relevant disease areas, from my perspective, I would receive less pushback regarding garnering support.
Mhm.
And along that line, we did have a question about whether or not you'll be publishing any of this data that you've presented today.
Yes, we expect to next year.
Right. A couple more that I have. Okay. So through your experience working on programs for the LGBTQ plus community, was one thing that you think you have learned that you didn't know before?
So much. I really thought that I kind of harkening back to the one evaluation comment, I feel like I'm an ally. I have transgender cousins. I really felt like I knew a lot. And once we started planning this and working with our planning committee and working with our faculty, who shared some really powerful things, I realized I didn't know anything. And it really took me back a little bit to think, oh, here I am thinking I'm an ally and I'm doing this great education and this is fantastic. And then going through it and thinking, oh my gosh, I didn't know any of these things or any of these things that were happening to people, especially as it related to their healthcare.
Is that what it was for you? Do you think it was like the experience that people had that was eye-opening in particular?
Yeah, for me, I mean, one of our modules, one of the faculty talked about a patient being physically assaulted in an exam, like physically hit. Like I can't even get my brain around that. And it was things like that that came up with our planning committee, who the majority of them, identified as LGBTQ plus, and just telling stories of people they knew or things that had happened to them was really moving. And I think that's part of what has made me so passionate about this topic.
Yeah, no, absolutely. No, I think those stories are very powerful, and I think we've seen some of that, through the data we've collected, through the qualitative insights we shared. One thing, specific that was kind of eye-opening to me in the case study that we shared was just the fact that patients are reporting that they're providing this data around their sexual orientation and their gender identity, but providers do not know how to access it. So that information is available. And, if you think about it conceptually, there's logistical and workflow challenges that exist with other, in other categories and other areas that we're trying to drive improvements for. Some of those same fundamental things exist for care of this patient population. So it was just eye-opening to me to see nearly 100% of the patients reporting they're filling out this information, such a small percentage of providers knowing where it actually is.
Mm-hmm.
Yeah.
Rachel, any other thoughts?
Yeah, final thoughts. I was really surprised at the huge amount of discordance between what the HCPs think experience their perceptions versus what the patients experience and their perceptions. I didn't think the gap was going to be quite as astounding. So I really feel like this education, is just so important.
And then one last question that came in. Any opinions on why we don't see more of these types of, it says questions, but I think they mean programs?
Well, I think it goes back to one of the things Rachel was speaking on, that, like younger generations are feeling more comfortable coming out and identifying as LGBTQ plus, whereas previously, look like even 5-10 years ago, there was more hesitancy to do that. So I think there's, I'm hopeful that like moving forward, we'll have more of these programs. There'll be more of a spotlight, more of attention on some of these inequities in healthcare for this population. But I think the reason why previously is because of hesitancy among people in this community to come out.
I think that's part of it for sure. I think maybe organizations don't realize how big of an issue this is specifically until they start delving into it. For us, it's funding. And anyone who's heard me talk about this topic has heard me talk about that, because I can't quite figure out how to put some things into the buckets that could get funded. We would really love to do some transgender education. And, I've had folks from the industry tell me, okay, well, if you could put it into a certain bucket, then we could fund it. So if you could come up with something where it had something to do with dermatology or it had something to do with plastic surgery or something, but that's not really where we want to go with it. But I understand, the imperatives of the industry and how the therapeutic areas are key. So it does make it a little more challenging to get funding from my perspective.
Yeah, no, I agree. I agree with you, Trish. I think it's key to fund potentially grants with overarching health equity interwoven into everything that we do. And then perhaps, particular modules for marginalized communities and special populations. And I think that helps garner that support.
Mm-hmm.
We actually just got one more. Just a little bit of a hot button topic, so respond as you feel comfortable to, but I'll put it out there anyway. A comment on that, a DEI has been, a hot topic for, a number of different areas, including CME, past few years. However, it seems that perhaps LGBTQ plus issues have not been as high on that priority list. Any thoughts on how we could bring light to this topic and raise awareness to that this is an important DEI issue as well?
Mm-hmm.
Yeah, I would just go back to the relevant disease, tying the LGBTQ community being underserved and their delayed diagnosis, poorer outcomes, and tie it to that therapeutic area and share that with my internal stakeholders. And that seems to help.
Yeah, I agree. Being able to tie back to the patient impact, quantify the gaps that exist, from an outcomes perspective, that should help make the case, I would think.
Yeah, and I think having strong advocates within the organization is helpful as well, because there's always, in our organization, we call them our pillars, and there's always a variety of pillars that we're focused on each year. And they can be very disparate. One of the pillars is related to climate change, and then you've got LGBTQ and different things. So it's a matter of having advocates in this area who can help you elevate that particular topic area as something that needs to be a higher focus.
Yeah, I think that's a good point. We got a comment in as well. This was before this question even came up. I think it's related. More of a comment than a question, but basically just talking about how that this is something that probably should be promoted in clinicians' curriculum throughout the the lifespan, not just in CME, but in med school and residency and
and
that would go ahead.
No, that's an incredibly valid point. One of our faculty and someone that I've worked with on planning other initiatives as well is with Outcare Health. And he always talks about how he didn't learn anything in medical school related to this. It was maybe, half a chapter that they went through and on to the next thing. And so that's something that they've made a priority in working to actually try to change that, which I think is great. He's in a better position to kind of advocate for that with his organization. And they actually just did a webcast on that very topic. So if anyone's interested in that, it's Outcare Health. and they do archive all of their education. So
That's great. That is all I have in terms of questions. Any final thoughts or anything you want to add before I go into my final few slides?
no, I'm just grateful that you were able to have us on to talk about this today. I think it's so important.
Yes, thank you. It was a great opportunity to be able to do this.
Yes. Thank you, Derek. Much appreciated.
Yeah, no, and thank all of you for being willing to come on and talk about, a topic that sometimes is uncomfortable for people to talk about. So I appreciate it. This was a great session. Thanks for all the information that you shared. So let me go through right from talking about that too. We have a scavenger hunt that you can participate in if you haven't already. Our promotion sponsor is Skin, Bones, Hearts, and Private Parts. You can go to their website, look for the CME Palooza logo, and click on it and see what happens. We do have a survey this session. One of the big pushes for me to try and find some folks that will be able to talk about this came from our survey where this was listed as a topic of interest. So please, if you have a moment, take our survey. Let us know any ideas that you may have of future topics that you'd like to see in CME Palooza. We'd be happy to hear those. And then lastly, our last session of the day is improving patient care. That's the one we're on right now. Let me turn the page. Fade Out HIV, Connecting Black Barbers, Their Clients, and Community Clinicians, which is sponsored by Platform Q. Some of you may remember that in the spring, we were supposed to have this session, and it got canceled because of a tornado warning for a couple of the members who had to go off. So this is not a repeat because I didn't get to do it, but a continuation of the session that they weren't able to do. So hope you can all join us. We'll start right at the top of the hour, 4 p.m. Eastern. So you have 8 minutes to go and get another cup of coffee or any other refreshments. But with that, I'm going to thank everyone. Trisha, Rachel, and Chris, if you don't mind, just hang on after I end this. But everyone else, thanks again and enjoy the last session of the day.